My name is Lisa Newman. Again, thank you for having me. I've had the honor of serving as the director and the founder for the International Center for the Study of Breast Cancer Subtypes, or ICS-BCS, for the past 20 years. I know that the mission statement for aortic reads as follows: to transform cancer control in Africa through collaboration in education, research, and delivery of equitable and timely interventions to minimize the impact of cancer. And our goal with ICS-BCS, as shown in the next slide, is well aligned with the overarching aortic goal. We strive to reduce the global breast cancer burden through advances in research and delivery of care to diverse populations worldwide. And so, unlike aortic, we've kind of limited our scope to cancer of the breast, although our focus over the past 2 decades has been in Africa, as well as studying African ancestry populations in the US. But we do also have goals to study breast cancer across other parts of the world. So in that regard, we do differ a little bit from the overarching aortic goals. We have been extremely gratified by the research opportunities that have been afforded by our ICS-BCS partnerships, and we've benefited on both sides of the ocean from the powerful and meaningful friendships that we've been forging. And these relationships have actually been the foundation for several capacity building programs that have served our ultimate goal of improving the care and outcomes of breast cancer patients worldwide. On this slide, I summarize our history. We began at the University of Michigan with our international partnership built on the shoulders of a maternal and fetal health exchange program that was established by Dr. Tim Johnson. And our growth was definitely catalyzed by the recruitment of Dr. Kofi John to serve as our program's director. For a brief period, we were headquartered at the Henry Ford Health System in Detroit, Michigan, until I relocated to Weill Cornell here in New York City, where we've been based since 2018. Now, Comfort remains our most mature research partner, but we do have many exciting collaborations with the St. Paul's Hospital, Millennium Medical College in Addis Ababa, Ethiopia, partnerships in Calabar and Enugu in Nigeria, Kampala in Uganda, and the St. John's Hospital in Antigua in the Caribbean. Recruitment highlights include the 6 years when Dr. Melissa Davis served as our scientific director, and our ability to recruit and retain Brian Stonecker serving as our ICS-BCS Director of Laboratory Services and Research. And then most recently, Dr. Vivian B., who you will hear from, was named our Associate Director. Our academic accomplishments include several of the publications, and this is just a partial list here. And I do want to highlight the fact that our team was actually first to document the correlation specifically between West African genetic ancestry and hereditary susceptibility for triple-negative breast cancer, in contrast to East African genetic ancestry. And all of the publications listed on this slide, as well as all of the other publications that we've had, feature co-authors from our multiple institutions. The next couple of slides simply demonstrate our rewarding visits to different countries in Africa and working side by side with our research and clinical colleagues. We always bring all of the supplies and resources that are necessary for doing this clinical work in the operating room as well as in the outpatient clinics. And we've been able to establish some wonderful immunohistochemistry programs to support our pathology colleagues, plastic surgery programs to establish breast reconstruction, as you'll hear about. We launched our international ICS-BCS annual symposia 8 years ago. Very recently, we established a monthly didactic session for the trainees across both continents via Zoom technology. We've established 4 needle biopsy training programs so that our colleagues can make their breast cancer diagnoses more efficiently. And we were also very proud to be able to launch the Comfort Teaching Hospital Telemedicine Conference Room, which serves the purposes of supporting collaborations across multiple different disease sites internationally. And now I want you to hear from our partners, some new, some much more seasoned in working with us over the last 20 years, but they've all been sharing their wonderful time and expertise in achieving our mission over the last 2 decades. So I will turn the virtual podium over to Professor Kofi John, who's going to run the show. Thank you very much. Kofi, we can't hear you.
Yeah, I'm trying to
now we
share.
can. Okay.
Yeah. Can you please see my slides?
Not
No,
yet,
Kofi.
Kofi.
How about now?
No.
Not yet.
Boy. Come on.
Do you want them to be shown centrally from the aortic offices? Oh, now I think yeah, now we see you. Great. Thank you, Kofi.
Okay, you're next.
Yeah, I'm supposed to talk about challenges and benefits of global partners in cancer research. Yeah, I mean, we have a lot to say, so I'm just going to limit it. Some of the challenges, as you can see, we're going to start with the RB and ethical review committee approval and material transfer. As I'm indicating, it varies from country to country. And I'm glad to say that Ghana, which is the African flagship of ICA-BCS, has the most simplest one. The simplest one in the sense that we work at Confondation Teaching Hospital. Of course, they have the ethical review committee. We took a president, they approved it. There's no government involved. I mean, once it's the agreement between the two institutions. On the other hand, let's see Nigeria. Nigeria, we have two sites, as Dr. Nima mentioned, Enugu and Calabar, University of Nigeria Teaching Hospital at Enugu, University of Calabar Teaching Hospital. Once you get the RIB approval, it has to go to national level, the Health Research Ethical Committee. They also have to approve the RIB protocol. The same applies to Ethiopia. Ministry of Science and Technology also has to approve it. Then Uganda National Council of Science and Technology has to. These things can take months, not weeks. They can take months. So those are some of the challenges. But since we are aimed to do this, we continue. I mean, work very hard. I mean, to get the approval so they can do the work. And the next one, I would say importation of reagents and antibodies and surgical, medical, and research supplies. That one too, there's a headache. But I'll use Ghana as an example. Suppose we want to bring something to Ghana. First, we list whatever we are bringing, whether antibodies, surgical supply, medical supplies, or research supplies. We write a cover letter and go to Ministry of Health, Procurement and Supply. They look at it, they approve it, then go to the Chief Director, Ministry of Health. So also look at it and write a letter, and the letter has to go to Ministry of Finance that the Ghana government is not going to make any money of this. And also write another letter and it go to the Customs, General Revenue Authority. They are the one actually who collect the money, whether at the port or at the airport or whatever it is. They also write a letter. The commissioner write a letter addressed to his deputy commissioner. So there are three deputy commissioners, one at the airport, one at the harbor if you come by sea, and one at the border if you come by road. But ICBCS, most of them will come by air. So you go to the deputy commissioner at the airport. You also write a letter, then go to the arrival hall where the team will bring these things. So once you get your arrival, they have their copy, you also have a copy. Then once they see, then they will allow us. And this thing can take days, and I mean, even I think a couple of weeks. And we work in Kumasi. So I tell my project coordinator how to travel to Accra to do this. Or I myself will go early and get this thing done before the team comes in. These are some of the challenges. Yeah. So Nigeria, similar thing, they have their National Agency for Food and Drug Administration Control. They also have to do the same before you can bring anything. Ethiopia has their Ethiopian Revenue Customer Authority. So basically, these are some of the challenges that we face. I mean, but the work has to be done. The next thing I want to take the benefits. Dr. Newman has alluded to most of it, but in this international collaboration partnership, you will agree with me that the first international collaboration, knowledge transfer, then address disparities. You know how the cancer patient benefited from, as you can compare to Africa. So disparity, we try to close it, reduce cancer incidence, enhance understanding of cancer biology. Oh, these are some of the benefits that we had. Improve screening and early detection, and improve treatment options. The Genema travels to Ghana almost 3 times a year to do studies and everything. And whenever you go radiation oncology, medical oncologists, all of them, they help our collaborators. And of course, publications for our collaborators. As you know, right now, publication also, some of our collaborators in Africa to advance their career. And the last one is to increase clinical trials. There, I would say, ICABC, we are not there yet. Dr. Bion, you agree with me. You spoke passionately about this at the last outing meeting. So Dr. Chen, that's what he's doing now. So when it gets to your turn, I think we talk about a little bit what ICBC is doing to bring clinical trials into Africa. Yeah, so that's my last slide. So thank you for your time. So I'm going to leave. Then Dr. B.
Hi, all. While Kofi pulls up my slides, I just want to say it's an immense
So this is Dr.
pleasure.
B.
Can you hear me? Okay, good. Immense pleasure to be here with you today. Kofi's going to pull up my slides. We don't see it yet, Kofi.
You don't see your slides?
No, I see your slides. So make your slides small. And
yeah, I think you're going to have to stop sharing, Kofi, and then because you probably have it as a separate presentation for Vivian.
Mm-hmm. And while Kofi pulls that up, I can actually start talking. We know that in the United States, there are opportunities to improve quality improvement through quality improvement initiatives. And we think that there's an opportunity to do the same on the continent. And so today I'm going to talk about at least one quality improvement initiative, service quality initiative that leads to improved outcomes for our patients. And just to give a little background, in the United States, we have an American College of Surgeons, and they have really done a great job in outlining an opportunity to have accreditation for breast programs that meet certain standards. And that accreditation program is called NAPBC, or the National Accreditation Program for Breast Cancers. And the NAPBC really aims to improve optimal resources for breast care through multidisciplinary team approaches, quality improvement initiatives, like I mentioned, patient-centered care, clinical trials, survivorship, community outreach. It goes on and on. It's a really thick book that we sort of follow to improve our the quality that patients have who have breast cancer in our outcomes. And so there's one quality improvement program called ERAS, which is Enhanced Recovery After Ambulatory Surgery. And its mission really is to improve the surgical outcomes for surgical patients. So you can go to the third slide, Kofi. Through a comprehensive approach to patient care. I'm just gonna third slide. Number 3. Yep, perfect. Comprehensive approach to patient care. ERAS really takes a holistic approach to the management of the patient's journey through pre-surgical preparation and post-operative recovery. evidence-based practices that really show enhanced patient recovery and improved outcomes through reduced complications, shortened hospital stays, and to overall enhance the well-being of breast cancer patients. And the ERAS program, and I'll get into sort of the nitty-gritty with it, but it really is an opportunity to work collaboratively with breast surgeons, nurses, the anesthesiologists, physical therapists, and nursing staff to improve the patient's outcomes and their overall experience. Next slide. And so when we think about the ERAS program, there are a couple of parameters that we like to focus on: providing patients with preoperative education to understand what their patient surgical journey is going to be, enhancing their nutrition for the best healing opportunities, to really think about multimodal pain management, early mobilization, and to follow standardized care pathways. Next slide. In our program at Cornell, we actually have two different ERAS programs, one for our plastic surgeons and one for patients who are plastic surgeons who have flaps. There's an ERAS pathway for that. And then patients who have mastectomy surgeries with or without plastic reconstruction and actually with their dissection. Next slide. And the quality metrics that we follow are improving length of stay. We know that if we can be thoughtful about the patient's treatment journey, even before they make it to the OR, that we can really limit their pain, get them up and moving, and improve their outcomes through decreased pain, decreased narcotic use, and postoperative complications. Next slide. Pre-surgery, this is the day of surgery. We provide patients with acetaminophen. They have a thoughtful multimodal pain management approach with our anesthesiologists and surgeons combined. Education. We also provide wipes so that we can decrease infection. And again, the education. Next slide. In the OR, the whole team is really thoughtful about the whole patient experience. Plus or minus with different surgeons, whether antibiotics are given. We also think about keeping the patient normothermic, so they're not too cold, not too hot, improving their pain, not overloading on the pain management, providing euvolemia throughout the case. And then most importantly, I think is the regional block, which we do as breast surgeons or also allow our anesthesiologists, and it's really placing local numbing medicine under the pectoralis muscles and blocking those nerves, and that has been shown to decrease postoperative pain, but most importantly, decrease the need for narcotics. Next slide. And so this is just a quick tutorial of how we place the pec block, and this is using bupivacaine within the dissection plane of the pectoralis major muscles, major and minor muscles, to block the lateral and medial pectoral bundles. In the postoperative, next slide, the patients receive non-narcotics like acetaminophen, sometimes NSAIDs, and just pain meds, PRN, as well as compression bra will improve or encourage getting up and moving around. Next slide. And so the ERAS program is really just one opportunity for quality improvement initiatives that we believe can be extended and should be extended onto the continent. There are, it may seem daunting, but there are really just some key things that making those changes will we know, improve patient outcomes, like patient education, prepping the patient, collaboration amongst surgeon and anesthesia teams, and we know that this leads to decreased readmission rate, decreased postoperative pain, and increased patient satisfaction. Thank you.
Yeah, that's the last slide.
Yep, thank you.
Yes, Kofi, she said thank you. So you go to the next presenter.
Yeah.
Okay, that will be you.
Oh, okay. Can you pull up my slides then? I didn't know that. So I will talk about, my name is Dr. Ajay. I'm a pathologist at Konfano Teaching Hospital, and I also double as the ICS-BCS pathologist for the Africa sub-region. And I think Dr. Abiola, we met in at Aortic last year. We were in the same car to the hotel, if you remember the face. I will talk about what ICS-BCS has been doing on the continent of Africa to improve access to simple or basic biomarkers for. Can you hear me?
Yes, we
well.
hear you, Ernest. We just need your
Okay,
slides.
great. Yeah, okay. Yeah, so what we have been doing on the continent of Africa to improve access to basic biomarkers, and so Kofi, you have problems pulling it up. The first thing is just to, as Professor Lisa Newman said, when she arrived in Ghana somewhere in 2004, as a researcher, her focus more was on training, transfer of knowledge, developing capacity in the surgical field and others. And somehow about 8 years down the lane, in the spirit of making sure that there is some kind of equity, we needed to build the capacity to be able to test breast samples in Ghana so that the women or the patients who participate in this research get access to treatment based on their biological markers. And so in 2012, we had Kofi. You still don't have my slides on, but I'll keep talking. Maybe it comes up. Somewhere in 2012, we had a scientist and a pathologist, myself, come to Michigan to get a refresher training. And after we returned back to CAD, we got some supplies and equipment support to start IEC testing, especially ERPR-HER2. And since that time up to date, this has been the practice. It's been continuous program. But then about 3 years down the lane, somewhere in 2015, we then had this expansion phase of ICS, BCS, and pathology program, trying to reach out to many other regions within the African continent, especially where ICS, BCS presence is. And in Nigeria, we had 2 sites, and in Uganda, we are here to do something there. We have sites like Ethiopia. But our approach usually would be that to be recruited or to join this program, we will visit your site. We do a site visit. And then during this site visit, we try to engage with the authorities, especially the pathology unit, trying to look at their staffing strength, look at what they already have in terms of equipment, what they can do. If there are any needs for some gaps that we need to fill in terms of capacity, we do that. And then we move to the next phase. So Kofi, you can probably go to, I think, slide 4, because I've been touching on all the other slides.
This is 4.
Yes. So what we do is we do a site visit, and then in this at this point we kind of interact with the staff to look at their capacity and see where we need to build their capacity by way of diagnosis and also equipment complement of the hospital, looking at the total number of cases they analyze per year. And then when we are satisfied, we move to the next phase where we select staff to be trained on how to actually perform immunohistochemistry. And so we have the pathologist trained on how to read it, and then we have the scientist trained on how to perform the test. And after that, we go into implementation phase where we supply them with equipment, with consumables. And when they have started, we go back again to look at post-implementation visit where we try to look at if there are any gaps that we need to fill in. And we continue to support them. And after they have started, if there are any issues to be resolved, we do kind of remote support. And mostly we have a WhatsApp group that we discuss issues regarding supplies. We have this same group that we have issues if there are any troubleshooting that they need. Kofi, you can go to the next slide. So out of these visits, we have a total of currently 4, CAT, and in Nigeria, Enugu and Calabar, and then we have Ethiopia, who are fully functional now. We have Uganda and Zambia and Kenya, Machakos, yet to join the program. We actually did a visit in Sudan, but we are all aware of the political situation there. So we wanted to extend our program there, but we have actually suspended that. And you can see that on the graph, our locations currently on the African continent. We're trying to spread across to see how far we can go. Go for the next slide. Yeah, so moving forward, after we have established this, we have some planned activities that for the year 2024-25, we may have to carry on probably into the subsequent years. Those centers that are yet to be enrolled have been listed up there. We plan to have quality improvement on sample handling, and then this will take specific look at cold ischemic time and monitoring duration of fixation. These are very important quality metrics in breast cancer sample handling, and that we would want to make sure that these matrices are included in the pathology report. We are designing currently a template for reporting to make sure that we harmonize and standardize reporting of breast cancer samples across our sites. This is to improve on how that data is used for patient care as far as we are concerned. And the last point is to look at how we are going to introduce, we are emulating Professor Newman's initiative that we're going to introduce didactic monthly lectures that will start next year. Every month we will take a topic in pathology. And this will be for our sites, but it will still be open to any other pathologists who want to join. It will be an open access, not only limited to our sites, to organize these lectures during next year. Thank you very much.
Okay, the next one will be Dr. Che.
Yeah, hi everybody. I don't know if you can read my slides now.
Yep, looks good.
Beautiful. My duty is a very short one. I think I'll have the shortest presentation today. Mine is to discuss briefly expansion of breast cancer MDTs programs on the African continent. I'm sure we all are aware of the impacts MDTs have on breast cancer outcomes. It affords the healthcare delivery to be done in a very integrated manner. And for us on this continent of Africa, MDTs are absolutely invaluable when we think of the inputs we put in because of our very limited human resource, especially. MDTs in the African setting is naturally faced with challenges. We have a significant number of young patients. I was pleasantly surprised. I was in the UK recently for a training program, and I had the opportunity to join an MDT. It took 2 hours to be able to discuss 84 patients. This would not happen in my country because of the unique challenges of even the patients, let alone the logistics. We have very young patients. We have a very significant proportion of advanced disease. There are limited treatment options, limited systemic therapy, limited radiotherapy, etc. So once the patient is in front of you, the challenges go beyond the physical presence of the patient, unlike in other parts of the world, especially the developed world. This admixture of challenges and lack of human resource make MDTs on the continent, the output of MDTs suboptimal. To improve this efficiency of MDTs, especially in this part of the world, collaborations are the way. Leveraging on technology, especially teleconferencing. For us in Comfort and Noche, the impact of the telemedicine facility, which was implemented by ICS-BCS over a decade ago, has changed the face of our breast cancer MDT interactions. Now we have real-time interventions from well-resourced centers, people with much more experience than us on the continent. And this has really bridged that deficit our patients were suffering when we were just the only people in the meetings. The picture to your left is a typical example of an intense MDT. You can see the teleconferencing facility linking directly. We used to have a lot of interactions with the University of Michigan Health System experts, and now Weill Cornell Medicine experts. This has afforded our hospital the ability to get interventions in situations where we either lack human resource, we lack medicine, alternatives are available, etc., etc. We believe if this concept is adapted across the continent, where institutions in Africa get opportunities to link up with advanced institutions elsewhere in the world through the medium of technology and teleconferencing, the gaps we have in our continent will be very much improved. The facility as provided by ICS BCS has been made available to other MDTs, the gynae oncology team, the head and neck team. They all use these facilities, leveraging on the opportunities outside of Ghana to impact our patients. Ultimately, the patients are the beneficiaries. And we believe that this concept is spread across the African continent, much more patients will benefit. Thank you very much for your attention.
Okay, thank you, Dr. Che. The next in line is Dr. Hanan from Ethiopia, currently in Ghana.
Okay, hello everybody. Can you see my slides?
Yeah, they're coming up. Yes.
Yes, wonderful.
Okay, my name is Hanan Alabacho. I'm a breast and endocrine surgeon from St. Paul Hospital and from Sawa, Ethiopia. And I'm happy to be here, and I'm going to cover on ICS, BCS educational opportunities and fellowship in breast cancer genomics. So the educational opportunities, Dr. Newman has stated very well about the monthly didactic session, the workshop, annual symposium, and scientific sessions.
Yeah.
I'll go straight to the fellowship opportunity that I have received this year. And it's Gianni Bonadonna Breast Cancer Research Fellowship Award, which is given by ASCO Conquer Cancer, American Society of Clinical Oncology. This year's special award goes to Professor Lisa Newman, which she recruited me to receive this fellowship throughout the year. And it's done in collaboration with Yamachi Biotechnology, which is in West Africa, in Accra, in Ghana, which is founded by Dr. Yao Bidiako. It's a private limited company, and which is working relentlessly every day to change the cancer genomics dynamics in Africa. So the fellowship is a one-year program, and we are studying in breast cancer genomics landscapes of Ethiopian women. To be specific, we're doing whole exome sequencing of Ethiopian breast cancer patients from Ethiopia. This is achieved by hands-on training in the lab at Yamachi Biotechnology. And I have been trained in Accra how to extract DNA, how to do the QC, and how to do library preparation in sequencing. And I'm learning a lot on this. And also there is an online-based course from HMX Harvard Medical University, which covers on genetics essential and genetic testing and sequencing, also focus on cancer oncology and precision medicine, and it's very helpful and insightful. I've been learning a lot of important things on this online based course. And this is also has opened a door for collaboration between African countries, Ethiopia and Ghana, through ICS, PCS, and so pretty much that's what we are trying to do. The goals of this fellowship is, one is to contribute to the scientific contribution, and this research is going to be the first of its kind for East Africa, and in addressing disparity and having African exomes sequencing, knowing the mutation, the germline in somatic will establish a basis for personalized treatment, and it's a very important work to do. So the other thing is not to forget that is it has a significant role in career development and capacity building to the region, and it's very important to have a surgeon scientist trained in cancer genomics. So In summary, ICS-BCS not only plays a pivotal role in contributing in research, it also has a significant role in building capacity building, which ultimately enhances patient outcomes and lives and of breast cancer patients around the world. So finally, I would like to acknowledge to an absolutely wonderful and extraordinary human being, to Professor Lisa Newman, and who inspires me every day, and to Coffee John, to ICS BCS team, and also I would like to acknowledge Yamachi Biotechnology for teaching me a lot of new things and cool things, and for your hospitality. Thank you, Dr. Yao, and your team. And last but not least, to everyone who dedicates in their lives to fight cancer, and everyone who contributes in the fight against cancer in one way or another. Thank you so much. Amasagnalu.
Yeah, thank you, Dr. Hanan. Yeah, the next in line is Dr. Chen.
Hey, hello everyone. It's really my great pleasure to share some of our research progress. And well, Coffee, will you pull up the slide? So
You want me to share your slides or you're going to do it yourself?
do you want me to share my own? Okay, I saw.
Yeah, please.
Okay, just give me 1 second. Yeah, so I'm just putting up the slides. I'm a professor and the vice chair of innovation at Department of Surgery, and I'm very close colleague with Dr. Lisa Newman. And it's really my great honor. This year we start to develop a pipeline. We want to understand the tumor infiltration cells in the breast cancer. So we'll share you some. Can you see my slides now?
We do. Thank you.
Yes.
Okay, perfect. So, okay, just a very brief introduction about the center we recently built this year. It's called Center for Genomic Health. We use these organoid models to study, to model tumor progression and to understand how immunocells contribute to the tumor progression. Just a little bit background on the immunotherapy in cancer. There are three different approaches people are using right now, including the checkpoint kinase therapy like PD-L1, CAR T therapy, and cytokine therapies. And the CAR T therapy has been shown to work very well in the like liquid tumors such as leukemia. However, its activities in the solid tumor is not that very well known. And this is a standard protocol for CAR T therapy. We first isolate the T cell from the patients, and then we expand the T cell in the lab and deliver the CAR. And after modification, we grow millions of CAR T cells, and the CAR T cell will be put into patients and to kill the cancer sample. As I just mentioned, so it worked very well for leukemia. However, it doesn't work very well for solid tumor. One major challenge is that the CAR T cells cannot infiltrate the solid tumors. And in last 2 years, it's not a completely new topic. People has been working on that for two decades. It's called tumor infiltration lymphocytes. So, but in last 2 years, it's gained a lot of attention. The reason for that, the tumor infiltration lymphocyte is also called tail cells, which already exist in the solid tumor. So this immunocells already been exposed to different type of antigens in the tumors. So the right now, there are FDA-approved clinical trials. They can directly isolate the T cells and use it for different solid tumor therapies. But in the meanwhile, this is not a very completely new concept. Was initially tested in 1986, And then Dr. Rosenberger at the NIH started to work on human in 1988, around 4 decades ago. And yet just in the last 2 years, it's become a breakthrough in the patients. But the major challenge for the TIL field is how can we isolate this tumor infiltration lymphocyte? The traditional approach is we got the collaborate with surgeon like Dr. Newman and get the biopsy samples, and then we dissociate to make the single cell, and then we use some cell surface markers such as CD8 to label the cells, run sorting to purify the cells. But CD8 is not the ideal marker, and there is a patient heterogeneity that different patients, they may show different marker expression, and we don't really have a uniform marker. So last year, we got this new equipment. So basically, it is called Enrich Biosystem. It's a microscope plus a micro-well system. So it's here, it just shows a brief guideline. And then here you can do the this is a bioprinting system. So we can print around 8,000 micro-wells in each 6-well plate. And then we can plate down the cells. And because they are coupled with the immunosystem, capturing system, so that by tracking the GLP expression, we can actually capture the wells we want to keep the cells. And after the capturing, the remaining wells will be emptied out. And then we can dissolve it and retrieve with cells, and then use it to analyze, such as like single cell RNA-seq analysis. And we can also do negative selections. So this times we have both green cells and red cells, and we can eliminate the red cells. So this time we can only keep the green cells, and we can recapitulate the cells in different systems. So this is some real data we use for the use the biopsy samples from Dr. Newman's operation. So this is a patient sample we isolated. And from day 0, we do some staining. As you can see, there are only 2 T cells in this single well. And after 7 days culture, we can see the T cells expand significantly. And during this operation, we can also add the cancer cell in this well. So we can also real-time monitor the cancer growth. And if the tumor cell growth increase and cancer cell growth decrease, that means this T cell is really active. And then we can isolate the cells, and then we can use this. Most likely we'll do the single cell RNA-seq for the second generation, like short-read sequencing, or third generation long-read sequencing. So yeah, just very brief introduction about what we are doing together with Dr. Newman. And at the Center of Genomic Health, we also do a lot of drug discovery, and then the single cell multi-omics analysis. And I'm really looking forward to continue working with the team and to make more progress in the field. Thank you.
All right, thank you, Dr. Chen. Yeah, I'm not sure if Dr. Zhang is here. Other than we're going to jump to Dr. Adieza Momo, our breast plastic surgeon. Yeah.
All right, I think you can hear me, and hopefully you're beginning to see my slides.
Looks great, Adija.
Okay.
Yes. Yes.
All right. So good, I guess it's afternoon, evening, everyone. It's a pleasure to be here, and I really appreciate the opportunity to just share some of our work as it relates to a lot of the great things that are being done under the umbrella of ICS BCS on the continent of Africa. I think presenting on breast reconstruction towards the tail end of the session is great, just because it makes a lot of sense from the standpoint of breast reconstruction. Typically comes in the treatment experience of patients towards the tail end of that treatment experience. And so I'll get started. I have no financial disclosures. And thinking about breast reconstruction, I'm a plastic surgeon, and so photographs are part and parcel of our presentations. I'm not going to spend a lot of time on them, but breast reconstruction comes in multiple forms: implant-based forms of reconstruction, tissue-based forms of reconstruction, essentially with primarily tissue used from the lower abdomen allow us to restore the form and function of the breast after mastectomies are performed. And so that's essentially what we are talking about. When I talk with patients, I emphasize, at least in this part of the world, that breast reconstruction is not necessarily about survival, but about quality of life of women after they've survived treatment with treatment of their breast cancer. However, as I think about it, and I've spent time working on the African continent, I kind of get the feeling that this is not necessarily correct, that breast reconstruction in an indirect way can have an impact on survival. And some of the research that we're doing hopefully tries to touch on that. What you find is that mortality from breast cancer on the African continent is significantly high, even though the incidence is not as high as we might find in North America, for instance. Mortality is really high. And I think one of the reasons, not the only reason, but one of the reasons we found is that patients are really afraid of undergoing mastectomy. And there's a lot of literature talking about that. What we found in North America, however, is that with the availability of reconstruction, when women know about reconstruction at the time of their consultations, it increases their likelihood of considering mastectomy. And for patients who discuss reconstruction at the time of their consultations for treatment, they are 4 times more likely to receive mastectomy. So knowledge about reconstruction has the potential to have an impact on how patients view the treatment they're going to receive and the acceptance of the treatment they're going to receive. Trying to look to see what exists on the within sub-Saharan Africa, what we found is there's very little information on breast reconstruction. And for the few places where it exists, there are huge disparities in access to care. A lot of women are really not receiving breast reconstruction after undergoing mastectomy. And so this is, I feel through ICS, BCS has been an opportunity for us to make an impact and make some inroads in this area of care. And I've entitled this slide, Harnessing the Power of Collaboration. And I feel that ICS, BCS really provides the environment for a lot of us to come together as specialists to talk and understand the issues that exist and put our heads together to come up with some solutions that could be helpful in the long term. So I'm going to be talking in the next few slides, and I'll go really quickly about some of the early work we're doing, trying to make some inroads into reconstruction in sub-Saharan Africa. So when I'm thinking about research related to breast reconstruction, getting into this field, at least in that part in sub-Saharan Africa, what I realize is there's very little information and there's very little work that has been done. And so we have to start from scratch. And in order to build, a stable structure or at least anything of value, we have to have a good foundation. And so some of the work we're doing now is establishing that foundation for a stronger building as far as understanding how things are going to work and improving on access to care in sub-Saharan Africa. One of our early studies was a pilot study done on quality of life in collaboration with investigators at Confanoche Teaching Hospital and St. Paul's Millennium Medical Center in Addis Ababa, looking at their patient populations with breast cancer and undergoing mastectomies without reconstruction. This was a prospective study recruiting patients from both centers. And what we found, we were looking at quality of life in patients undergoing mastectomy alone. And what we found was that women undergoing mastectomy alone over time, and in the first at least 6 months after surgery, experienced a decline in some breast-related body image measures, indicating that they're slightly worse off. They're at least measurably worse off than they were before they underwent surgery. And so the question is, and this question has been answered in North America, but not necessarily in sub-Saharan Africa, is does reconstruction reverse this? Does reconstruction stand to change this experience for patients? With that information, or armed with that information, we started a study called the Sub-Saharan Breast Reconstruction Study, or SABRE. Sounds really nice, which is a mixed method approach to better understanding patient perspectives, knowledge about reconstruction, fears about mastectomy, and barriers to undergoing reconstruction. What we found early on have kind of demonstrated some of the sociocultural issues that patients consider when thinking about reconstruction or restoration of the breast. We've also picked up on certain things that will help with empowerment of women in making decisions for their care versus detract from that. Interestingly, we found that reconstruction knowledge is very low across the board. And for the group of women who happen to have more information, they tend to be less afraid about undergoing treatment. So with this information, what we've learned is that there is a possibility that we can change the trajectory of decisions that patients make, providing more information that they can make well-informed decisions, but also eliminating some of the fear that serves as a barrier to undergoing treatment or presenting for care at an early stage. And so our next step is to work on a culturally appropriate, tailored decision aid that would be available to women at the time of their consultations with physicians that might help change the way they approach the care. So hopefully, with the implementation of that decision aid, we'll observe less fear, earlier presentations for care, acceptance of surgical treatment, and also improved quality of life. Thank you very much for your time. I appreciate it, and great discussion.
Okay, thank you, Dr. Momo. Yes, shall we hear Brian? So Brian, who's in charge of our laboratory?
And just a special shout out to Dr. Momo for all the wonderful reconstruction work that he's already done on the continent of Africa during these visits, and the training that he's provided to our plastic surgery partners on the continent of Africa so that they can continue this work. Thank you.
Thank you.
Hello all, I'm Brian Stonecker. Hopefully you can see my presentation here. And I have the pleasure of representing the group of us in ICSBCS that work on recruiting patients and collecting for the biorepository. So as part of our mission for ICSBCS, we'd like to increase representation across the African diaspora within the scientific knowledge. And so here I've highlighted our sites in which we collect consent patients and collect biospecimens. So Confinoche in Kumasi, Ghana, University of Nigeria in Teaching Hospital in Enugu, and University of Calabar Teaching Hospital in Calabar, Nigeria. St. Paul's Millennial Hospital in Addis Ababa, Ethiopia. Here in the US, we have our New York Presbyterian network of hospitals for which we consent and collect biospecimens from 3 different hospitals. And previously in Henry Ford Hospital System in Detroit, Michigan, as well as St. John's in Antigua. And as you can see across, I've included our self-reported race numbers for our consented patients. And of course, our partners at Confinoche in Ghana have consented a far number of patients over the last 20 years. This is ICSBCS pilot site. We have thousands of Ghanaian patients, well represented in Ethiopia and Nigeria as well. And then the last few bars here, we can see across the Americas, over 1,000 African-American patients, 1,700 Caucasian, and hundreds of Asian, Hispanic, and those of other ethnic backgrounds. So as part of our mission to increase scientific understanding and representation. You can see our cohort of well over 8,000 patients, over half of which are patients from Africa, and about 2/3 are self-reported as African ancestry, which is really important to us. And in addition to collecting clinical data, we also collect several different biospecimen types. So from the time that the patient is consented, our fantastic coordinators will go ahead and collect saliva and blood when available. So we have thousands of saliva samples, blood samples, as well as we have collection of FFP tumor biopsy, surgical resection. We have upwards of close to, this number is probably a little underrepresented, close to 5,000 FFP tissue blocks, as well as in recent years, we started collecting fresh tissue samples from surgery for the use in organoids and fresh frozen tissue. And why this is important is it allows us to produce all sorts of data points. So in the last few years, we've been able to produce 177 tumor normal matches between for whole genome sequencing, as well as this includes RNA sequencing. 347 patients for which we've collected RNA sequencing, 122 patients for which we've been able to do ancestral panel sequencing, over 1,000 different genotypes, thousands of research-based immunohistochemistry slides, expanding into spatial omics with imaging mass cytometry from 30 different patients, as well as spatial omics with the 10x Visium and Xenium suite, and almost just up to 950 cases for which we've collected cytokine, chemokine, circulating biomarkers. And this all allows for us to increase the representation in the scientific literature. And lastly, and I know I'm brief on my slides here, but I really wanted to acknowledge our team. So here we have just a few of our members that provided their photographs of our clinical coordinators, which do an excellent job of reaching out to patients, explaining the studies that we're involved in. Our bioscientists, we have a few bioscientists represented here from our Nigerian and Ghanaian partners that makes this all possible, allowing us to collect patient data as well as biospecimens for our research. And it's a very complex and intricate workflow and logistical challenges that they deal with. And I just wanted to highlight them and show them our appreciation for that. Thank you.
Amazing the way you guys have all worked so tirelessly at amassing this very unique and special biorepository. Thank you, thank you.
Thank you so much. This is really very, very mind-blowing. And I know we are almost at the top of our hour right now. And I know a lot of people have questions. We're just going to quickly have a quick house rules that please endeavor to attend every month. This is on Tuesdays, first Tuesdays of every month. We're going to change the hour a little bit, an hour backward, for our East African colleagues and our Ethiopian colleagues to be able to attend, because it's like 9 p.m. at their time. And this session really is for us to learn what's happening in different regions, different institutions, an opportunity to foster collaboration and partnerships amongst us all. I did have some questions, and I know some people do have questions. If they do, probably we can put it in the chat. And I think that this actually calls for us addressing the challenges that was highlighted by Professor Kofi, which is we might start thinking about how can we get an IRB, IRB approval, right? Instead of going from one country to another, if we really want to move our research forward across countries and across regions. And then maybe we can start from a regional IRB, or how can we also address importation issues and bring in the customs to the table? Because, if our tissues, drugs, equipment are delayed in customs, it takes a little bit of time from us. And then I think this is something we have to start thinking about as a group and see how we can work towards this through the ERIC platform to be able to address this, because it's going to actually benefit us collectively. And I actually do have a question for the breast surgery, breast reconstructive surgical team, if you can quickly answer that, which is, you were talking about good foundations with regards to breast reconstruction in Africa. I was wondering if you had plans in training local plastic surgeons on breast reconstructive surgery. So, because with all this, I mean, if there's a lot of awareness for our patients as far as breast reconstructive surgery is, a lot of patients will show up with most likely early in their stages and would really want to get breast reconstructive surgery. And I just wonder if we'll be thinking about the bandwidth as far as training local team. And so I'll stop here. I don't know if you can quickly respond to that if you're still on board.
Yes, I can address that really quickly. So yes, what I focused on for this talk was primarily some of our research efforts, just given the limited amount of time we had. But the reality is research actually came after a lot of the efforts that were being made in teaching, education, and working with our surgical colleagues at many of these sites. Multiple times a year, we spend time seeing patients, working together in the operating rooms, and going over cases. And I think over time, there has been a growth in the experience of the surgeons that we've gotten to work with, and hopefully the trainees that are coming up under them. So it's going to be a gradual process, but all of the capacity building efforts through education and working clinically with patients are also underway as well, alongside our research efforts.
Thank you very much. So do we have any questions or concerns as we're trying to round up this session?
I just want to state that this is just a touch of what ICABCS is doing. So 1 year this time, November 2nd through 5th, everybody registered and come to Aortic 15 Biennial Conference in Hamad, Tunisia. You're going to get a very good dose of what we are doing. This were too many, we just limited it. Come and hear the work that we've been doing to much detail. Thank you. That's what I would say.
Absolutely. Hopefully, as we continue to do this session, I mean, this is not a one-off. We will continue to have this discussion. It's just not a Cornell hour, that is all. Cornell, we are part of ERIC together. So this is something we have to start bringing to the table for all of us to be able to collaborate, partner, and learn from it. And hopefully other countries that are not part of your team will be interested to jump on it. So thank you so much again. A big shout out to Professor Lisa Newman. You have been so wonderful. This has been mind-blowing. I just kept on writing and it's a lot to learn. Thank you so much, everyone, and we'll see you next month. Bye-bye.
Okay. Bye-bye.